very excited to have this, and I'm thankful to our guests, our panelists, Denise Figueroa from the Independent Living Center of the Hudson Valley, Brittany Wilson from the National Center for Law and Economic Justice, Todd Varwerk from Western New York Independent Living, and Jose Hernandez from United Spinal. I will just pause briefly, real quick, to allow each of the panelists to introduce themselves. Just, real quick, name and title, and something interesting about yourself for the community. Start with Denise.
Okay. Denise Figueroa. I'm the director of the Independent Living Center of the Hudson Valley. We're located in Troy, which is in the capital region of New York. I'm not sure that there's much interesting to tell you other than I've been around doing this stuff for a long time, getting older by the second. And I'm the original director of the center. So been here for 33 years.
Great. And I'll just kind of work my way across the screen as I see it. So Brittany.
Hi, everyone. My name is Brittany Wilson. I'm a staff attorney at the National Center for Law and Economic Justice. We're based in New York City, but we litigate nationally. Something interesting about me, I consider myself to be a writer first. I actually have a background in poetry and spoken word. As a teenager, I was on a show on HBO called Brave New Voices. And my signature poem from that series is a poem called Crutches, which is about my disability and my experience as someone with cerebral palsy.
Great. And Jose.
How you doing? I work for United Spinal Association, the national organization, and I'm also the president of the New York City chapter. I sustained a spinal cord injury about 26 years ago, and discovered my passion for advocacy about 9 years ago when I was invited to United Spinal Association's first Roll on Capitol Hill, which is a legislative event that they host in Washington, D.C., where they bring in 100 to 150 advocates to advocate from across the country.
Great. Thank you very much, and thank you for being here. And it appears that we may have lost Todd's video feed or internet connection. So hopefully he is able to join us again quickly. The pleasures of doing things via Zoom. So just a quick introduction for everyone, some ground rules of how this is going to go today. We have a number of questions we'll be asking of the panelists, and we'll ask each panelist to limit their answers to about 2 minutes, just so that we can cover the tremendous amount of ground that there is for consideration here. If you do have questions you would like to ask the panelists, we do not guarantee that your question will be asked, but we will be looking to take 1 or 2 questions from those who are listening in today. So please feel free to put those in the chat box, and I will be monitoring that, and we will work some of those questions in throughout the session today. And with that, I want to kind of dive right into the discussion. It's probably best to start with what is kind of an almost obvious first question, I think, today. Over the course of the COVID-19 crisis, many throughout the country have realized what the disability community has known for years, and that's namely nursing homes and other institutions are less than desirable places to live. While New York has reduced the number of nursing home beds by almost 2,000 over the last 5 years, there does remain a heavy reliance on these institutions. So in your view, what's one action that could be undertaken at the state level that would play a large part in shifting our reliance from institutional providers to a more community-based system.
Well, I'll throw some thoughts out there. You know, the state has not made it, you know, although the disability community has advocated for community first choice as being the first option to stay in the community with the right supports and home care, that is not what's been implemented here in New York. There are efforts to move in that direction, but the priority in terms of, you know, supporting the nursing home industry is, you know, what I think is one of the biggest problems, the profit-making industry that exists that, you know, relies on filling those beds. And New York State needs to really change the you know, the emphasis and make it more community-based. And unfortunately, we seem to be doing the opposite, which is cutting home care, cutting the very services that we're going to need in order to be able to stay in the community. Let's throw it out with that.
Yeah, my answer would be the same. It's a reallocation of resources, more support for home and community-based services, and not cuts like we're seeing on the horizon.
I'm going to add to that and say that, you know, there's not enough here in New York City affordable, accessible apartments. Only 7% of the units are set aside for accessibility, and only 5% of that are mobility impairments. So if you were born with or sustain a disability that requires a mobility device, a lot of the times you end up going from a rehab facility into a nursing home and then transitioning from there into your own home. So it's kind of difficult even to get out once you're in. So
Yeah, and that, Jose, thank you. That really speaks to the interconnectedness of really every issue. We tend to focus on the services themselves, but if you don't have a home, you can't receive services in the community. And, you know, as we look to reimagine the long-term care system, you know, we can speak to that interconnectedness, and two of the most interconnected and relevant factors are often that long-term care services are expensive, and that the state of New York is aging rapidly. In fact, according to the Center for an Urban Future, the number of seniors living in poverty has increased by over 10% in New York since 2007, which means Medicaid will be the vehicle that provides services as they become necessary. That said, in New York, Medicaid spending is currently capped, and the program has been run for at least a decade on what can really only be called an austerity budget, making it progressively harder to achieve funding levels most experts consider necessary to address problems in the system. Given this, what steps do you see as necessary for the state to take in order to accommodate the inevitable growth? And I'll just pause real quickly to welcome Todd back and say hi. So what steps do you see as necessary for the state to take in order to accommodate the inevitable growth in the long-term care system?
Nothing like starting out with an easy question, I suppose.
Right, I know.
I think we could start by recognizing that the system is a continuum. And if we're looking at saving costs at one end of the continuum by increasing cost in another, then we actually have to carry through on that result. We've been saying forever that home care is cheaper than nursing home care. Better medical outcomes, better social outcomes. We want people to be in the community, yet we're not decreasing nursing home beds, and their costs are going up. So this is a thing about looking at all of the long-term care costs as part of a continuum and recognizing that if you are spending money on community care, which you should because the results are better, then you really got to be going back and saying, all right, do we need as many high medically involved nursing home beds as we currently have? Just something to start, I guess.
Yeah.
Disagree with me. Come on, people, disagree with me.
I don't think any of us disagree with you. That's the problem.
Yeah.
There's got to be a holistic approach to everything. And I think that really is the bottom line to this. You said that it's not just housing that's integral to it. It's looking at people as a whole and all of the needs. And, when we keep everything so separate, we don't have a statewide policy on addressing disability or long-term care. And so for us to say what the state needs to do, the first thing they need to do is acknowledge that there needs to be a statewide policy on long-term care. There's just little pieces everywhere. And so much of it is driven by profit-making businesses that, we're never going to make a change unless we truly take a good look at the whole system. I don't know how other folks feel about it, but I think it's hard to say, what one thing or what anything they should do. There's been there's no even focal point on this. It is all just very piecemeal in the state.
Great. Denise, I'm sorry, Jose or Brittany, did you want to weigh in on this, or did they cover it all?
It's definitely difficult. You have individuals in nursing homes that don't need to be there at a cost that doesn't make sense. I can take you to a nursing home where there's a kid that literally grew up in a nursing home. He was there since he was 16 years old, and now he's close to 26 years old. That's 10 years of nursing home costs that could have been reduced drastically by giving him the resources that he needed to live in the community. That's one way of cost saving. So,
well, and what costs did they develop? Because what skills did he lose by being in the nursing facility and not being in the community? How much more are we spending because he's been kind of helpless in that environment through his formative years?
Well, I'm going to go back to when I was newly injured. I had 2 12-hour shifts at the beginning, the first year of my injury. And I had a city worker literally come into my house and say, you need to sign papers to accept a living case, or I'm going to place you in a nursing home. And I'm 16 years old. I was a year into my injury. And he says, it costs the state less, he said, to place you in a nursing home than it is to pay for 24-hour home care. At the time, I was naive and I didn't know that he was wrong. But I signed the papers. Thankfully, I wasn't placed in a nursing home. I finished my high school. I got a high school diploma, went on to college. Now I work, drive, pay my taxes. I don't need, the Social Security benefits. I actually pay more into taxes than I receive in, or I ever received in Social Security benefits. So that's one thing. Yeah, definitely a benefit.
The only thing I think I would add, I've been listening to a lot of really great disability justice panels lately, and one of the relevant points that I think I've heard a lot of people make is that right now in New York City in particular, we're seeing a lot of movement towards decarceration in the criminal justice context. So people recognize the problems of institutionalization when it comes to the criminal justice system, and oftentimes the disability community is left out of that perspective. And so I wonder if either there's something we can learn from that, or if we can figure out how to make our concerns their concerns as well, to figure out how we can alert the powers that be to the fact that these issues are connected, and that it costs less for them to invest in our ability to remain in community rather than being institutionalized.
Right. I mean, Denise said it. it's all connected. And the biggest failure in the system is the fact that DOH quite often thinks that it isn't, that they can move one piece on the board without affecting the rest of them. And that's just completely ridiculous.
So I'll just kind of piggyback on that. And this is a fascinating conversation. A lot of you are talking about, priorities and resources and the like. And what role does all of this play as we factor in the Supreme Court's Olmstead decision, which of course requires individuals the option to receive services in the least restrictive setting possible? Does it force the state's hand, and must we actually start to shift from these austerity policies in order to maintain compliance with Olmstead?
Yeah. Brittany, were you going to say something? Oh,
Go ahead.
yeah, no, absolutely. I mean, I think that we've got to force the state to implement Olmstead. We have we've had a most integrated setting coordinating council in New York State for 1,000 years at this point. That was their what they did to address Olmstead. Unfortunately, that's never been it's never been effective.
And only after we made them. Let's be clear about that.
Yes, right.
There was a protest in Corning Tower.
Yes.
Okay.
That we were both at.
Yep.
Yes, I agree.
My roommate here in this building was one of the Olmstead 8, actually. I see him every day.
Right. So yes, I mean, we've had to force the issue. We've always had to force these issues with New York State. They concede a little bit and then set up these things that don't really work. And that's the nature of bureaucracy and government and how they try to squash things. But yes, I think we have to force them to implement Olmstead, and it's the cuts in the home care, it's the lack of affordable housing, as Jose said. It's really and the low pay of the workers.
Yes.
So that even when you have home care, you can't find home care workers. It's really kind of a whole mess in this state, quite frankly.
Well, and the decision does say, because we're mentioning the decision specifically, it does say that there has to be a continuum of care, because some people are going to need the level of care that a nursing home requires.
Right.
So they were very specific about saying, well, we're not going to close the nursing homes down because, frankly, some people need them. But the right under the ADA is services in the most integrated setting. Least restrictive environment was IDEA, or Education for All Handicapped Children's Act, as my boss will correct me if I don't use it. But as we're looking at, what Olmstead does, it's not the beginning of the conversation, because we have the council, okay, and the council meets and they have a lot of conversations. And there's a lot of documents, and they're quite shocked when consumers show up and, tell their stories. But ultimately, if there's something policy related that comes from the council, I haven't seen it any more than I saw it from the Olmstead cabinet. Sorry, I had that right. Yeah. From the Olmstead cabinet, we're going to reduce our nursing home census 2% a year for 5 years, and then reinvest those savings back in the community. And they never actually made those numbers.
Great. And, I think I'm going to skip around a little bit in my questions here, because the topic of wages and pay for workers came up. And, realistically, if we want to build capacity within the community-based long-term care system, we have to recognize that New York is the epicenter of the nationwide home care workforce crisis. While CDPA itself has been used to kind of paper over this shortage to a large extent, our recent report, The High Cost of Low Wages, clearly shows that the program's by no means immune to the shortfalls or the problems that are caused by the low wages. And, indeed, national labor consultants, Mercer, have identified that the state will be short by approximately 30,000 home care workers by 2022. So apart from pay them more money, how do we address this shortage? Or have we just seen that the need is pay them more money?
I don't think it's just about money. Money is a major factor in it, don't get me wrong. But if you look at it as a whole, the community-based home care workers, they're really not considered part of the healthcare system. Nursing home workers are. I mean, look at how we responded to the pandemic. In the list of priorities for PPE, did they ever mention community care agencies except in the last kind of other category? No. Hospitals, emergency rooms, EMTs, nursing homes. And then after that, it's, well, after you've taken care of those, spread the rest out amongst wherever else. All right. So it starts by recognizing that the home care workers are part of the medical system. They're just as much heroes as the nurses and the nursing home people are.
But now that you mentioned them, I lost a home care worker to COVID-19 in April. And at the beginning of the lockdown, they weren't even included. They weren't even mentioned as essential workers. So we had to scramble and let the mayor's office for people with disabilities know that our home care workers are essential workers. And if they don't show up to work that Monday of the lockdown, then you're going to have a lot of individuals with disabilities showing up at hospitals that were already, inundated with people, and exposing even us to more of the disease. So thankfully, we got the word out. Brian helped put out a PSA to make sure that they know that the home care workers were essential workers. So
Mm-hmm.
yeah.
Yeah, but it's part of that argument about what to do with the workforce. The workforce went through a period where they were devalued. They were placed on a lower level of financial impact than fast food workers, right? Now we're in a pandemic where the home care workers are the afterthoughts. I think money is part of it, but you got to treat the home care workers like they're important. And in a lot of cases, treat them like they're professionals, because the sense about consumer directed is it's family members taking care of other family members. So that's not really professional. That's just, we're paying them to take the time to care for them. I don't have a family member that does my care for me. I don't do it that way. I hire a professional. I train that person. I support that person. Now, I'm not saying that, family members caring for other family members is necessarily a problem, but we got to get the sense that regardless of who they are, they're a professional and they're part of the healthcare system. And then we can work on wages and benefits.
Yeah, well, it definitely is an issue of dignity of work and
Mm-hmm.
recognition, by the community that these are not only essential workers, but as you said, they're professionals that shouldn't be looked upon as the lowest, level job. And that's the problem. It's not viewed that way. And now with the cuts in, being proposed by the state in, for home care across the board and consumer directed in particular, and all of the managed care organizations, which is another layer of this, you have managed care organizations that expect you to only pay minimum wage to the personal assistants. They're including in their rates only minimum wage. And that, again, you know, limits the ability to hire people. It certainly sends a message that your job isn't even as important as working at a fast food restaurant. And it just complicates the matter even more.
Well, you're coming into someone's home for $15 an hour and taking care of some of the most intimate, you know, things around. You know, I need assistance, you know, going to the bathroom. I need assistance showering. I need assistance, you know, preparing my meals. You put them in front of me. I can feed myself, and that's not the case for everyone. But on top of all of that that you're doing for me, you also have to take care of my home. And for $15 an hour, you can stand in one solitary spot and flip burgers.
Yeah.
So it makes it extremely difficult.
Go.
I mean, I think part of this is preaching to the choir, but I think one of the barriers to the money and to them being recognized as healthcare professionals is ableism and the population that they serve, and that their work is not viewed as the same way a doctor's work would be viewed, because of the nature of the work and the population that they're serving. So I think that as part of our advocacy around wages and all of these other issues, we have to literally combat the views of ableism, and that people with disabilities are not a clientele that is serviced by valid healthcare professionals.
I think you called it. You absolutely called it. It's ableism. We're considered the poorest of the poor, the lowest of the low. So the people who take care of us, well, they're doing us a favor. So why would we bother to want to pay them? No, that's ableism.
Right.
Absolutely.
They even lack a sense of, I guess, progress. Because you can work with the same client for the same amount of money for 10 years and never get any recognition. You never get any way of progressing into, it's just a job. This is just something to sustain you until, just to pay your rent, get food. There's no way of elevating yourself.
Yep. And sometimes we get lucky and aides stay with us because they create a relationship, and sometimes we don't, and they'll abandon us the minute the fast food job opens.
And so I'm going to take a question here from the chat box. And Jose, this really piggybacks on the point that you made at the very beginning of the webinar. Governor Newsom of California has a plan for housing all Californians, not in nursing homes. It's a real plan, though obviously a big challenge to implement. Is that one thing that we as a community should be demanding of Governor Cuomo? And of course, this comes with the caveat that yesterday, Governor Newsom proposed cutting all home care by 7%. So, minuses.
There's legislation already out there called the Disability Integrations Act that creates a plan from the moment you go into a nursing home and gets you integrated into the community. I think that definitely, if you don't know about that, look it up. Disabilities Integrations Act. Ask your representatives to, you know, sign on to that. If they're not ready, this creates a plan. It's not going to be the perfect solution, but it's a solution that we have right now. But definitely reduce nursing homes stays, create more accessible, affordable, accessible, make the subsidies work, because there's a couple of subsidies out there that, you know, say that they're helping individuals, but they aren't. You have the nursing home diversion waiver program that is extremely difficult to get onto and has been in a weird spot where it's supposed to be transitioned over to the long-term care, but
Yeah.
that's been going on for the last 2 years. So I don't know. Things need to change to make all the connections work.
True. Can we demand it of Cuomo? Sure. Should we? Just him? I'm going to say no to that. I think we can demand that he bring leadership to the issue, but that's not just on him. And it can only be on him for the state dollars that the state spends in terms of social determinants. He needs to create the leadership, but then there's got to be federal dollars that come in to support that and start looking at the true nature of that stuff. I mean, for example, with housing, if we promoted new housing to be extracted, accessible from the word go, and not just the 5 and 2%, but at greater percentages than that, then we wouldn't be have to asking for separate money for affordable and accessible housing. That, you know, our flexibility would grow as new housing was built and constructed. But we don't want to, go ahead.
I was just going to say, but you'd still need the affordable part, because
Yeah,
you know,
true.
you'd still need, you need the subsidies, or you need the low income housing. There's no low income housing being built, you know, and that's a serious problem for our community, and particularly in cities where it's totally not affordable to live for anybody.
And we should expect the governor that used to run HUD to understand that and to dial into that particular social determinant. Does it answer your question, Brian?
Yes. I mean, this is all fantastic conversation so far. I'm really enjoying this. I hope everyone is. I want to kind of switch up a little bit here and just note that, you know, another factor that the current crisis from COVID has really forced us to confront has been the role that health disparities play in the overall health of our communities. And within long-term care, we've seen this in the death rates in institutions, as an analysis conducted by NPR actually demonstrated that the nursing homes hardest hit by COVID-19 in New York had one common thread: the number of minorities residing inside. Again, citing that Center for Urban Futures, the populations most likely to need long-term care services through Medicaid in the future are immigrants, African Americans, Asian Americans, and the Latinx community. So, you know, therefore, it becomes imperative that we actually address this issue. And what investments or changes can we make in our community-based long-term care system to ensure that we're minimizing or even eliminate the impact of healthcare disparities? Not at all ambitious.
I feel like that's a huge question. I don't even begin to pretend to have an answer to that. I lost my aunt to COVID, and she's in a nursing home. So I know just how real this disease is and its impact on disabled people of color. I don't even begin to know how to answer that question.
Well, I'm going to start by saying it isn't just disabled people of color, it's people of color. Because as it turns out, people of color are the majority of the home health workforce in most of the places that I know. I'm in Buffalo, New York, for those people that are watching on the cameras, and I am literally a block and a half away from the zip code with the greatest number of COVID cases, right? And my neighborhood is predominantly African American. I'm a rarity in my neighborhood, and I'm okay with that. But it's about the healthcare disparity. Disability just makes it worse. The healthcare disparities for minorities, including our workforce, is the thing we have to tackle. And that could be from better screening and dealing with ongoing conditions in that population, like the explosive growth of diabetes and high blood pressure, to dealing with food deserts. Because the thing that you become what you eat.
Right. I mean, Oh, sorry, I didn't mean
No,
to.
go ahead. Go ahead.
Well, I want to,
Oh,
I just want to say that I live in the Bronx, and I live in the zip code where you have the most positive cases. 42% of the people tested for COVID-19 are positive. So I think one of the issues was at the beginning, no one came out to our neighborhoods. You know, I live in public housing, and there's nothing but a bunch of public housing developments in my neighborhood. They didn't come to the public housing and say, hey, you know, you should socially distance. You should wear a mask. You should this. You hear it on the news, but it's not directed to the individuals living in these communities in their languages. Forgot to mention languages. There's a lot of language barriers. And there wasn't a plan. They didn't say, okay, we're going to clean the high touch surfaces, you know, every day. We hear it in the MTA that now they're cutting, they stop services overnight so they could sanitize the trains for the essential workers. But what about those who come into our homes and we live in public housing? They stated that they were going to clean the elevators 3 times per week. So on Friday morning, they clean the elevator. Someone with COVID, you know, touches the elevator and it stays infected for 72 hours. So until Monday morning that they come in, the COVID-19 is still on the surface of the elevator, and people aren't socially distant, not wearing masks, they're not wearing gloves, and they're packing the elevator. So you need to get into the communities and say, hey, you know, you need to stay safe and socially distant and isolate. And they're not doing that.
Yeah, and what does socially distancing mean in an apartment building where you're sharing ventilation and you're sharing garbage slots and mail slots and yeah.
And that's why I didn't have an answer to this question, because I mean the answer is all of the forces that we've been talking about, right? I'm in Brownsville, born and raised in Brownsville, which is one neighborhood over from the area in Brooklyn that had the highest per capita COVID death rate, which is Starrett City. So this is all my neighborhood. I mean, I want to say institutional racism, right? But like, how do we even begin to address that? If we know that NYCHA, you know, can't even address its mold issues, how do we begin to address how you socially distance when, like you said, you live in housing projects where that's not possible all the time? You mentioned the food deserts. You mentioned, you know, the health disparities that come out of these communities just by virtue of the fact that the way that we live, which is related to, you know, our race, our socioeconomic status. So these are huge questions. Yeah, that I think involves everything that we've been talking about.
Well, let's not forget lead abatement and availability of primary care, because emergency rooms are still the #1 source of medical care for at least the minority people in my community.
Well, and if you don't have health insurance, that's exactly where people are going to go. And so
Yep.
you get, you know, to the whole issue of the fact that not enough people have health insurance, and it's still tied to your employment. And even though we've got enhanced Medicaid in New York, you know, to get people enrolled in the healthy in the New York healthcare system, it still isn't enough. There's still uninsured people, and then, you know, you have the folks who are undocumented, who, you know, it's a whole other group of folks who are exposed because of it.
How are we doing on that answer, Brian?
Yeah, it's really depressing, isn't it?
Yeah.
I think Brittany, you summed it up perfectly in saying, you know, we could probably spend an hour just scratching the surface of that topic. But it is important because I think it goes through all aspects of this. I mean, we know that as marginalized as the disability population is in itself, it's that much worse, or if you're a disabled person of color, or a disabled immigrant, or a disabled individual who doesn't speak English as its first language. And so all of this just continually layers on top. And actually, I'm going to go off script for one moment here off of my questions because
I'm like, wait, there's a script?
I have one. Um, Brittany, you brought up just the institutional racism that drives so much of this. And when we were talking about the workforce, what role does not just the population that the workforce is serving, but the fact that so much of the workforce is women and predominantly immigrants and women of color,
Yep.
play in how this workforce is viewed, particularly, as somebody said, this is a skilled job. Home care requires a particular skill set, and within CDPA, oftentimes people are doing nursing tasks. So, would we tolerate this in the nursing industry that often looks very different?
No, the easy answer is no. I mean, it plays every role. I mean, it's this crisis has shown us exactly who is essential, and unfortunately for us, those are the people that we tend to disregard the most and pay the least, and that's not by accident. I feel like all of my answers to your questions seem like overly simplistic, but I mean, I feel like these are forces that we've known about, we know about, and have known about for years. And the question is, how do we change it? And that's the work that I've been trying to do every day as a civil rights lawyer. And I don't have sort of a neat answer to it, but I think it's amazing that when all of us, including myself, I recognize the privilege of being able to work from home as an attorney, and that's sort of part of, I guess, a workforce that some people might consider elite, but the people who literally, some people,
Yeah, no, not so much, no.
some people, air quotes.
Right.
But I recognize that, the people who literally make our lives go around and hold our lives in their hands are women, people of color, everything we just said, who didn't get to stop going to work.
I learned a long time ago that there is a deliberate separation between education and skill.
I'm going to add that, when the pandemic was at its height and New York needed nurses badly, they sent out an alert and it's like, hey, if you come to New York, we'll pay you more. So a lot of individuals came from all the states and says, you know something, I'm going to get paid twice, 3 times what I'm making in my state for 12-hour shifts. I'm going to go, granted, they're risking their lives in the epicenter, but that incentivized them to leave their homes, put their lives at risk, and come take care of individuals with COVID-19 in New York City. Doesn't that speak to the fact that if you want individuals to come into people's home and do home care and take care of us, feeding tubes, trachs, bowel care, showering, doesn't it lead to the fact that you should pay them more and they will come? Nurses were coming from all over the country because of the money and because, some of them had a sense of duty. But money is definitely an incentive.
Certainly is. Everybody has to pay their bills, and everybody, people have families, and that is, the bottom line is that we do need to invest more money in home care.
Well, and also to recognize that nursing and home care are part of the same system, but we have to recognize that those single moms, okay, are at those social determinant disadvantages, and it would be right for us to shore up those disadvantages wherever we can. But if we're training them and they're getting training and supports, they become skilled whether or not they get a certificate that they get to put on the wall that says, I'm skilled, I can do this. Go ahead.
You can train your service dog, and the federal government protects him. You can train your home care worker, but the federal government does nothing.
I think that's the point, isn't it?
Todd, you were making a really interesting point about education and skill. I don't know if you finished that point, but I was really interested in
it. He actually kind of got to it, but the part is true, because I'm torn between whether I should demand the best training from the people that work for me to guard against infection and to do all those things, or whether I should be able to say, look, does it matter how they were educated, as long as they can pick up the training to remember to keep things sterile and to follow the process they learn and to do the things that I need them to do. Now, recognize I'm a consumer-directed person, and we're talking about the entirety of the long-term care system here. But Jose went right to the end of my point for me, and he said it far better than I ever could. Because if we are training them, once they're trained, whether they're educated or not, they need the respect and the dignity and the protection in the system, because they still have value. This isn't something that you're going to pick up for the summer, do for 8 weeks because you're going to need money, and then off you're going to go to college. The people that we're dealing with, this is the way they feed their families.
I completely agree with that. I thought the point you were going to make, and I think this goes back to what we were talking about before, in terms of the populations that they serve. If we talk about skill versus education and even training, I think the issue is society does not view these workers the same if they are trained by us.
Right. Right. No, you're absolutely right. I mean, I grew up in a world where there was an academic path to success and a technical path to success, right? Plumbers, woodworkers, car mechanics, all that stuff, right?
Right.
That went away in our modern educational system, at least here in New York. We're not doing that. Everything is all about meeting a minimal academic requirement. But one of the skill sets that we've forgotten on that technical end is care, long-term care. That's a skill in the same way that car repair is a skill. Although, you know, I do recognize that that's kind of a crass comparison, but it's true. And I think that that's where we got to be able to say, we're going to support people that want to get as much education as they can, but the training should be enough to give them the respect to be part of that field. Because I wonder if it wasn't nursing, Jose, if we put out a call and said, you know, we need long-term care people in New York and we'll pay you more because, you know, we're at the epicenter of crisis, whether or not home care workers would get on buses out of a sense of duty and land in Buffalo and start looking for clients.
The answer is no.
What is the, you know, what is the difference?
In that crisis for years.
Right. But the difference in that is that nurses see their academic skill as having a particular value.
Right.
Okay. So much so that it goes back to that money thing, but not just that. Even the ones that are coming out of a sense of duty are saying, I'm going to take the professional training that I fought hard to get, and I'm going to put it to use where it can do the most good. Why can't aides think like that?
Yeah. So, this fascinating discussion, but I want to get to one more point here, and we have about 10 more minutes. And, you know, one other factor that we have to consider as we envision a new long-term care system is the fact that New York is a large state by Northeastern standards anyway, with a tremendous amount of regional diversity. And in many of the areas of the state, it's a point of pride that one can go from the middle of an urban setting to the middle of nowhere in about 20 minutes. And so to what extent are the different solutions that are required in Buffalo as opposed to New York City? Or, you know, when we consider Buffalo or Syracuse or Albany or New York City compared to the rural communities that are often lacking in basic public transportation and other measures.
Well, speaking from Buffalo, whether it's urban or whether it's rural, transportation is at a crisis for healthcare workers. Transportation even in the city of Buffalo where I live is not so broadly defined as it is in New York City. I got to, for those people that don't know, I have an underground train that is partially above ground that runs in 2 directions on 1 street. And then the rest of it is bus service, which ebbs and flows depending upon where the bus company can make money in fare box recovery to make the rides. So the transportation crisis is almost the same in an urban setting as it is in a rural one. So it's one of those items where, do we want to strengthen the long-term care network? Then we have to look at that social determinant of transportation, not just from a mass transit perspective, because in Buffalo, increased mass transit would help out a little, but out in Sardinia or Eden, okay, the only way you're going to get people is to ride people or drive people.
And I'm going to say that goes again with wages. If you can pay them better, then they can afford their own transportation. Because in rural areas, no matter what you do, you're going to have those individuals who live way out there, and you're going to need to take a bus or provide some kind of paratransit services for them.
Right.
But those deserts are going to be difficult to service.
Yep.
But
And
even in the capital district, we've got bus service in the 3 cities. That's primarily where everything is. But, all you have to do is go outside of the city of Troy, and the rest of Rensselaer County or the rest of Albany County has pretty much no access to any public transportation. So you can't even get folks who can afford to have a car to get out to somebody in the rural parts of our counties. And that's why CDPAANYS has actually worked so well, because they can hire neighbors, right? The home health care agencies can't even fill jobs that are outside of the cities.
Well, and I wanted to make sure that we raise that a little bit, because we talk an awful lot about why home health care is so expensive. I was in a conversation with another IL staff member recently, and I explained to them that the true failure was the failure of not keeping aides in the traditional system. Because as the traditional system failed to take cases, the companies sent cases to consumer directed, or the counties did, because back then it was before MLTCs. The counties sent the cases to consumer directed because they didn't want to have to handle the drama. We'll make it the consumer's problem, and they'll hire who they can hire. It'll be their problem, not our problem, right? And that's how we got to these supposed explosive growth in consumer directed, because they didn't support the other spaces in the continuum. So if we're looking at how we're going to change long-term care coming into this incredible opportunity, we've got to see that. And being able to drive people, or being able to get transit opportunities for people, becomes critical in making all of that system work. The reason that they shut down the trains from 1 to 5 p.m. was so that the nurses could get to work, right? Now, according to the governor, I heard him say it like 6 times.
Great. So I'll just ask one or two, kind of one word, if you all want to just respond with 1 or 2 words. Don't worry, the questions are set up that way.
Quick fire.
In terms of, to kind of round out a couple more pieces here, the role of private insurance companies such as MLTCs and mainstream Medicaid plans, as well as commercial insurance, has been a big factor of conversation lately. And, one aspect that the disability community has always been aware of is that if we need services, we have to qualify for Medicaid. And so it's almost forced impoverishment, or at least forced impoverishment capped at $56,700 or something. So as we move forward, what is most effective if we're going to move forward with a comprehensive plan for long-term care services? Is it our current managed care system? Is it a return to fee-for-service in Medicaid and keeping this healthcare system on the larger community? Or do we need to move forward with some sort of single-payer option that has a long-term care benefit?
Yes.
The private insurances don't do it because it's the kindness of their heart. They're making money. And all the services that they cut, they make money. All of the individuals like me who require 24-hour care, they lose money. So they deny us. They want to give us live-ins and stuff like that. And now with all the cuts in Medicaid, it's only going to get worse. This government in New York City saved so much money on the Consumer Directed Personal Assistance Program. That's one of the reasons why they expanded it. But they didn't realize that opening it up to 1,000 fiscal intermediaries was going to cause the jump that they saw. And some agencies might have done it the wrong way, but it's a needed service. You know, you have the Consumer Directed Personal Assistance Program where people are doing nursing home level of care, like Todd mentioned, and they're getting paid minimum wage. A nurse comes into your home to change a catheter, and it's $200. And that's not an hour, that's $200 per visit. And you're paying someone 12 hours, $15 an hour for the entire day. To do that, you know, same thing, the catheter change, to do the showering and clean your house and cook for you. So it's a win-win for them, but they still, they don't consider it enough.
Capitation is literally killing our people. That's it.
Right.
Capitation is literally killing our people. So, Brad, I don't know if it's possible to answer that question in 2 words, because I don't know if a single payer system will solve that problem or not. I certainly know that the MLTCs weren't ready to be handling people with high care needs like the ones on the panel.
Right. And that was our concern all along with managed care, was that they can serve people who don't have high needs, but anybody with high needs, it was going to cost a lot of money. But it's not just the managed care. I mean, it's, you know, when you're talking about, you know, even on the fee for service side, them wanting to limit and change the way, you know, they pay for things and reduce the cost. I mean, there are going to be a lot of people with disabilities who are going to suffer. And now with the new changes to the ADLs and eligibility, you know, we're talking about more people, you know, who aren't going to get the service that they need in order to be able to stay in the community. I think that the disturbing thing about all of this, you know, even the attacks on the growth of CDPA, the assumption is that there didn't need to be growth in CDPA, but the truth of the matter is that they underestimate always the needs that are in the community, you know, whether it's for seniors and people with disabilities. And, you know, the underlying assumption here is that we need to limit, but in fact, as we're aging, the needs are growing, and there's no acknowledgement of that on the part of the state.
And Brittany, we're at time, but I want to give you the chance to make one last remark if you want, either to the question or something else.
I don't have anything to add. This has been a great discussion.
Great. So with that, it is about 5 o'clock now. I want to thank all 4 of you for participating in this today. It's been a wonderful discussion. I did see a couple of comments in the chat box about the lack of closed captioning, and I do apologize for that. No one has speaking of skills, no one has the skill set in our office to be listening to a conversation and typing it at the same time. And, that in and of itself is a very strong skill set, which is, I think, how Zoom actually does closed captioning. So we have recorded this, and we will be putting closed captions to it and putting it up on YouTube. So this will continue to exist through that venue, and there will be a closed captioning option available in the future. We'll also look at other ways to close caption in real time these conversations, because for the audience, one thing we do want to do is move forward and have more of these conversations. This is not something that can really be handled in one call, and we want to get a strong diversity of viewpoints on this issue. So please look for future conversations, and thanks again to our panelists. I will note that one of our colleague organizations in the Coalition Carrying Majority is beginning their own panel right now on workers in your home, and working with workers in your home. So if you haven't seen that, go take a look at that, and I would encourage all of you to just move right on to yet another Zoom panel. And from there, I will end by once again thanking Denise, Brittany, Jose, and Todd. I'll thank everyone who tuned in today. And with that, have a great day and be safe out there.
Bye.
Bye-bye.
Thank you.